Hello, everybody. My name is Hugh Hagan. I'm a member of the Carilion Clinic Department of Orthopedic Surgery in the section of hand surgery. And what I'd like to do today is present to you osteoarthritis of the CMC joint of the thumb, updated to this year. I have no disclosures or conflicts of interest regarding this presentation. We're going to talk about several things: anatomy of the CMC joint, the pathogenesis of primary osteoarthritis, the demographics, who gets it, and treatment, both non-operative and operative. First, let's talk about the anatomy. We're going to discuss bone, ligament, tendon, and muscle. The bones that are involved: metacarpal and trapezium, the ligaments, the dorsal ligamentous complex, which we'll talk about a little bit more, the transverse intermetacarpal ligament and volar beak ligament, the involved tendons, the flexor carpi radialis, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and the flexor pollicis longus, and finally the intrinsic adductor pollicis. The take-home messages on the anatomy portion of this section are that the volar beak of the metacarpal articulates with the recess in the trapezium to provide bony stability, and the dorsal ligamentous complex is the key soft tissue stabilizer of the CMC joint. And through this presentation, you'll see references below that you can refer to later. So the CMC joint is a biconcave universal joint. What does this mean? It means it's stabilized in flexion by the articulation between the volar beak of the metacarpal base, as shown in the cartoon to the right, and the volar recess of the trapezium, which is also shown in the drawing. The and tension on the dorsal ligamentous complex when the CMC joint is in flexion. Pathogenesis of the problem is likely a combination of ligamentous laxity dorsally, which leads to dorsal subluxation of the base of the metacarpal, followed by impingement volarly, leading to erosion of the beak articulation on the distal portion of the thumb metacarpal. Ligamentous laxity is in part due to the presence of estrogen receptors, which are present in connective tissue, and women have a higher concentration of these estrogen receptors or estrogen-like receptors, which tends to lead to an increased connective tissue laxity. That may explain why you see it a bit more in women than in men. The volar beak ligament, shown here on this photo, is a reactive capsular thickening that occurs when the volar beak wears out and the joint starts to sublux dorsally. It becomes much more prominent. So is the volar beak ligament the primary stabilizer of the CMC joint of the thumb? And the answer is probably not. The dorsal ligamentous complex is the primary CMC soft tissue stabilizer. MCP hyperextension laxity is also present in many of these cases, and it may be a causative factor. When you flex the MP joint of the thumb, this normally will cause a volar translation of the base of the metacarpal. And if the thumb MP joint is extended, normally this will cause a dorsal translation of the metacarpal base. So chronic hyperextension of the MP joint will cause the base of the metacarpal to shift dorsally. In other words, the thumb CMC joint will sublux dorsally, and that increases the volar beak impingement and wear. And chronic dorsal displacement of the metacarpal base will lead to increased wear of the volar metacarpal base and the dorsal trapezial cartilage, and you'll end up with osteoarthritis. So correcting MCP hyperextension can decrease dorsal metacarpal base subluxation. MCP hyperextension can also be a secondary deformity, which still exerts the same sorts of deforming and destructive forces at the base of the thumb metacarpal. And this results from loss of abduction of the metacarpal. So hyperextension of the MP joint would be compensatory, moving the metacarpal base dorsally and leading to a worsening of CMC subluxation and increasing wear and tear in the CMC joint. So in cases in which you have to do a CMC arthroplasty surgically, correction of the MCP hyperextension can prevent recurrent basilar deformity. And the degrees of hyperextension and the recommendations for that we'll cover a little bit. but suffice it to say it can be anything from splinting to fusion and soft tissue procedures in between. So what's the pathogenesis of arthritis with the scaphotrapezoid joint? Generally, this is referred to as an Eaton stage 4 arthritis. What do you do with the joint between the scaphoid and the trapezoid? Is it resected? Is it fused? There's support in the literature for doing everything from nothing to fusion. Andrew Bridgeforth had an article recently in Journal Hand that talks about ways to manage both STT arthritis as well as MCP hyperextension, and I would refer you to that for a further discussion on the subject. So, summary of anatomy and pathogenesis. The CMC joint of the thumb is a universal biconcave joint. The volar beak of the metacarpal articulates with the volar recess of the trapezium in flexion and is the primary osseous stabilizer of the CMC joint. The dorsal ligamentous complex tightens with CMC flexion and is the primary soft tissue stabilizer of the CMC joint. And once the volar beak disarticulates, MCP instability and tendon and muscle forces will act to perpetuate dorsal subluxation, and this leads to worsening arthritis at the base of the thumb. MCP hyperextension is generally going to be considered contributory to both the pathogenesis as well as the perpetuation of dorsal subluxation. So who gets it? Well, 30% of women over 50 will get it, and a significant percentage of them, probably 50%, will be pretty symptomatic. A little less common in men, and they're a little bit older before they start having symptoms from it. It is the second most common site of arthritis in the hand, the DIP joint of the index finger being the first. Symptoms and clinical appearance do not always correlate, nor do x-rays. Eaton in 1987 proposed a classification system radiographically in which a stage 1 Eaton CMC arthritis was just joint narrowing, a stage 2 less than 50% of the joint is subluxed with small osteophytes, and a stage 3 more than 50% with larger osteophytes, and in a stage 4 you get arthritis all the way around the trapezium. And this classification is descriptive. It's a handy shorthand technique for describing the x-rays. However, it's not prognostic. So let's talk about some non-operative treatments for basal joint arthritis. They fall into categories that you'd be familiar with. First, rest with splinting, supervised stretching, therapy, strengthening. You want to get help from your hand therapist. This can actually be pretty helpful, and combined with anti-inflammatory agents and sometimes an injection, can get people to the point where their joint has become less symptomatic. We encourage the patients to cope with this as long as they can, because at least in my practice, probably 50% of people that show up in the office can be nursed along to the point where they don't need to have an operation. Study by Swigert, presented in the Journal of Hand Surgery in 1999, really showed no significant difference by modification of activities with the results of treatment non-operatively. And that neoprene splints and hard splints and gloves all work equally well, but there tends to be a bit more compliance with things that are comfortable. So hard splints can often be discarded. There are a variety of splints that can block MP hyperextension if that's a portion of the pathology, but oftentimes these are fixed deformities that don't respond to splinting of the MP joint. Oral anti-inflammatories can be considered, particularly when there are other joints that are involved. COX-2 inhibitors such as Mobic and Celebrex are often better tolerated than COX-1 anti-inflammatories, and they have fewer side effects and don't end up needing to be taken but once a day. So most people can remember to take them. If this is going to be a chosen path of treatment, enlist the help of the patient's primary care physician, since any side effects the patient might have would be medical in nature and require the assistance of an internist. Potential side effects, well known to people: stomach upset, bleeding, kidney problems. Before you start anybody on an anti-inflammatory, look for those three things. Are they on an anticoagulant? Do they have a history of gastric ulcers? And do they have normal renal function? Topical anti-inflammatories are pretty safe. In my practice, have been pretty effective. I'm certain there's a potent placebo effect with these, but I certainly do have a number of patients that have done very well with topical ketoprofen or diclofenac. These tend to be very safe treatments. They're inexpensive. It's debatable how effective they are. There's some soft support in the literature for it, but it's a good way to get a patient started on thinking about non-operative management of their hand, particularly when it's combined with therapy. Other topical meds include capsaicin or its cousin capsidin, which is compounded capsaicin with a carrier that gets it through the skin without creating a burning sensation. You can inject the CMC joint and buy time with this, particularly in older patients. Dexamethasone or Kenalog are generally what I use. Use a little needle. You can put it in at about 20 degrees to the perpendicular. With or without ultrasound, you inject a small amount, anywhere from a half cc to a cc, and try very hard not to put it under the skin, because this is an area prone to skin hypertrophy and depigmentation. What about operative treatment? This falls into several categories: the no trapeziectomy procedures, trapeziectomy alone, partial trapeziectomy with an implant, complete trapeziectomy with an implant, or trapeziectomy with suture or ligament stabilization. Good review in 2011 in the Journal of Hand Surgery. Some of the no trapeziectomy procedures include denervation, which is gaining some popularity, simple ligament reconstruction described back in the 80s by Eaton and Littler, metacarpal osteotomy, and fusion of the thumb CMC joint. So talk first a little bit about joint denervation. This is surgical excision of articular branches from the radial century, lateral antebrachiocutaneous and palmar cutaneous branch of the median nerve, branches into the articular capsule of the joint. There is some growing support for this in these three articles that I listed here. They have a growing body of follow-up. However, it's unclear just how long this procedure will last, and there's some concern about the potential for particularly radial sensory neuritis. We've all been trained to keep our hands off of these sensory nerves at the level of the wrist, and so I would exercise caution if this is a procedure you want to embark upon. But the preliminary results are pretty good. Other no trapeziectomy procedures include simple ligamentous stabilization, such as Eaton and Littler described in the 70s, where 50% of the flexor carpi radialis is used as a transosseous and subosseous stabilization of an otherwise early arthritic joint. This wouldn't be done in a joint that was already collapsed or subluxed. Osteotomy to change the metacarpal alignment is a closing wedge osteotomy of the metacarpal base. This has been described several locations, most recently in the journal Hand in 2014. The Mayo Clinic experience with this has been good. My experience with this has been good. But once again, you're doing it in very early stage, Eaton 1 or early Eaton stage 2 hands. And I think it's probably a procedure you'd confine to the younger patient population in which you're trying to preserve some bone stock. A closing wedge osteotomy is cut from the base of the thumb metacarpal about 30 degrees, closed, fixed internally. I use a locking plate screws. The original description was with K-wires or a tension band wire, which works well, generally younger patients. And what this does is, as the thumb flexes toward the palm, there's a tendency for the base of the metacarpal to shift volarly more because you've got more room to flex. And this can reduce the joint in the position of greatest vulnerability, which is in pinch. And then what about arthrodesis? Well, there's a higher complication rate, failure of fusion, hardware irritation problems, but results are comparable to other techniques. The 2017 review showed fusion and LRTI arthroplasty to be comparable. Better internal fixation, as demonstrated by Marco Rizzo, has improved the results of fusion. So it's something to consider. However, its complexity and slightly higher complication rate would mean that you'd really want to consider hard what the advantages of a fusion would be in your particular patient. All of this is pretty well outlined in Marco Rizzo's presentation from the Hand Society in 2022. And trapeziectomy with no internal stabilization, sometimes called hematoma distraction, sometimes K-wired, sometimes not. This produces over time good results. This has been more popular in the UK than in the United States over time. And trapeziectomy with implants, multiple past implant designs, always a red flag. Why isn't there just one? And that's because they all have a higher complication rate than the other procedures, but when they work, they really work pretty well. The initial implants were made of silicon, either a hemiarthroplasty or metal-on-metal implants, all of which had a high failure rate. Cemented implants have a high rate of loosening in the metacarpal and trapezial bone metacarpal interfaces. Trapeziectomy with a silicone implant was still done when I was in training. And then when I was a fellow, we were taking them all out. And now nobody does it anymore because of fragmentation of the implant under axial load and synovitis associated with that. A partial trapeziectomy with little tiny total joints cemented, promising initially, but the bone cement interface is a problem. And these often failed, disarticulated, or loosened. The European literature has a 10-year follow-up on a pressed fit hydroxyapatite coated implant called the MAIA implant. It's only available in Europe at the time, but a level 4 10-year follow-up showed 88% implant survival. This was presented in the Journal of Hand Surgery in 2024. It's worth a read. It's a cute little implant. It looks like the cemented one, but the pressed fit feature of it seems to give it some longevity. Partial trapeziectomy with hemiarthroplasty, the Stabilix hemiarthroplasty, promising initial results, but it has shown a higher failure rate and a higher need for revision for a variety of problems, all of which contribute to pain and weakness. And then finally, trapeziectomy with some form of stabilization boils down to suture stabilization or tendon stabilization. Suture suspension procedures are good. Level 4 studies, all with excellent results over a 5-year period. Jean Del Signore, Arnold Peter Weiss, and Jeffrey Yao have all shown studies that document good long-term results. I'm quite familiar with Jean Del Signore's and Arnold Peter Weiss's procedure, having done a number of these over the years. I've been less of a user of the mini tightrope just because of the unique complication of metacarpal shaft fractures, which I've tried to avoid. LRTI and similar procedures using tendon instead of suture are still probably the gold standard in North America. This was described by Burton back in 1986. Wildby, Vermeulen, and Amadio all had similar procedures using different tendons. Total trapeziectomy with ligament reconstruction and tendon interposition is what most North American hand surgeons will do. About 85% of surgeons use this procedure, perhaps by habit, perhaps by training, but certainly it has very solid, good long-term results with a much lower complication rate than all the other procedures, with the possible exception of suture suspension. Here's a cartoon demonstrating this, and even though it's kind of confusing, the thumb is on the top. It's labeled metacarpal 1. It demonstrates the flexor carpi radialis drawn through a hole at the base of the metacarpal, stabilized at that level in some fashion by suture or interference screw, and then rolled up or turned into an accordion and tucked in under the metacarpal. Stabilization with K-wires, or as I do, no stabilization with K-wires, provides a good posture for the thumb to be supported postoperatively in a splint. I'm going to show you quickly 3 sets of photos that are just surgical examples from my own practice, to show you how I tend to do the more common procedures with the thumb. The first will be a trapeziectomy, LRTI. In this particular case, I'm using the Arthrex interference screw. That's not absolutely necessary. You can always suture the tendon. The Arthrex set has some very nice tools that make it slick to transfer the tendon through the bone and stabilize it. Then we can talk about simple suture suspension, and we can talk about salvage using suture suspension with a bone anchor. For LRTI, your choice of anesthetic is appropriate. One of my partners does these under a wide awake local anesthesia only technique. It's effective. It's a little bit technically more difficult because of bleeding and some swelling during the procedure, but it's doable depending on the patient and their anesthetic risk. You use the entire flexor carpi radialis. If it's small, like 4 millimeters, you use the whole thing through the bone. And if it's bigger, I'll split it in half and place half of it under the metacarpal and half of it through the metacarpal. And this takes under an hour generally. So here's some pictures. This is a lady who had an instability of her MP joint in addition to her arthritis. So I did an MP fusion for her. Here's her joint instability. So I've done her fusion already. Here's her trapezium exposed through a Wagner approach, taking care to avoid injury to the radial sensory nerves. This photo demonstrates the scapulotrapezoid joint, blue arrow on the right, and the flexor carpi radialis tendon is demonstrated by the blue arrow on the left. Dorsal to all that are the tendons of the abductor of the thumb. Here's the flexor carpi radialis tendon under the edge of a Ragnell retractor. Here it is again through a small incision, exactly 1 Hagen finger length from the tubercle of the scaphoid. Here's the tendon after it's been drawn subcutaneously and dissected down to its insertion at the base of the index metacarpal. I've got 2 hemostats on it. To handle it in this fashion, it can either be split or it can be rolled into a little knob so it can be passed easily through the base of the metacarpal. Generally, if it's 4 millimeters or smaller, you wouldn't split it. So here's a guide pin from the Arthrex kit going through the base of the thumb metacarpal, pointing toward the insertion of the flexor carpi radialis. Here's the drill that goes over it. And generally, you want to run this on an oscillating mode so you don't wrap up any vessels or nerves in the vicinity. Here's the tendon with a suture placed at its base to help roll it into an accordion as an interposition. I generally will use a 2/0 Ticron suture. It has a non-cutting needle, but your choice of a braided non-absorbable is fine. This is a little tendon passing gadget that allows you to pass a device through the bone that will then capture your tendon and allow it to be pulled through the bone. And here's the tendon pulled through the bone, the metacarpal positioned, and an interference screw being placed. Here's the flexor carpi radialis tendon following its exit from the thumb metacarpal, and the previously placed Ticron suture is woven through it to form an accordion, and you just push it down the suture all the way into that space beneath the metacarpal, and then suture it down tightly and close that interval that you created to expose the trapezium. Be sure that you don't enclose or include the branches of the radial sensory nerve with your closure. That'll give people a tender place and a numb thumb. So that's an LRTI in a nutshell. The complications particular to this are tendon rupture, which is pretty rare, stretch and subsidence, which is pretty common, but typically doesn't produce symptoms, and then proximal impingement from the metacarpal, which you can avoid by rounding off the volar part of the metacarpal, something that you should pay attention to, because with this, there's often a bird beak osteophyte volarly at the base of the metacarpal that you want to try and get rid of so it won't impinge with the trapezoid. So what about suture suspension? Basically similar. It's quick in most cases. Similar photos, stabilization, MP joint in another patient. There's the FCR tendon. You pass a heavy suture. Generally, I'll use a number 2 fiber wire through the abductor insertion, through the FCR, and you can tie it off or run it through twice. But the idea is to not pull the FCR up under the metacarpal base. It's to build a little hammock of suture. And it's also good if you can put the knot underneath the abductor so that it's not right under the skin. And you tie that off and you close it up, but don't get that nerve. And that's that. And it's pretty quick. The complications here would be rupture of the FCR insertion, and you can avoid that by not strangulating the tendon when you're putting your subarticular suture in. Subsidence also somewhat common, but once again, painful impingement is rare, but round off metacarpal. Finally, what if you don't have an FCR, or what if this is a revision of a failed LRTI where you don't have a tendon to use? There are other procedures. You can use the abductor pollicis longus. You can split the ECRL and run it through a bone tunnel in the index metacarpal. What I've chosen to do is just use a bone anchor with heavy sutures and run it under the thumb metacarpal base to do something similar to the prior suture suspension. If this is a thumb that's never been operated on, it's a half an hour operation. If you've had prior surgery, it's a little bit longer, but tends not to be too difficult. Here we are with everything exposed and the trapezium is gone. The freer is pointing to the articulation between the index metacarpal base and the trapezoid. A hole is drilled right up the intramedullary canal of the index metacarpal through this incision. Sometimes you have to remove just a nibble of the scaphoid so that your angle can be correct, but this is just confirmed by doing it very slowly and gently using the drill provided with this particular bone anchor set and the C-arm for guidance. This happens to be a titanium suture anchor from Mytech, a helix anchor with 3 orthocord sutures. And you use those sutures underneath the base of the metacarpal and not through the metacarpal, as I learned the hard way by putting it through the metacarpal and then in and out with orthocord articulate synovitis that required revision. But I haven't had this problem using this technique if it's not run through the metacarpal itself. This provides very stable reconstruction. And much like the other suture suspension, you can move a patient relatively quickly. So complications with this include anchor pullout, which I've seen once, and suture abrasion and particulate synovitis if you run it through the bone. So make sure the person's not too osteoporotic to do it. Make sure you have a good bite in the bone and make sure you don't run it through the bone. So for all forms of trapeziectomy, subsidence doesn't necessarily mean a bad result, but impingement between the proximal metacarpal and the trapezoid should and can be avoided by rounding off the base of the metacarpal. So common post-op recommendations include a bulky compressive dressing for a week. At the first visit, you can take your sutures out, put steri-strips on the wound. You have the patient seen in OT so they can have a splint made with the thumb in palmar abduction, the IP joint of the thumb free, the fingers free. You keep them in that until 4 weeks post-op and then start working on range of motion out of the splint. And at week 5, they're seen back in the office, and if they look good and if their x-rays don't show excessive subsidence, I start working on strengthening at that point. I tell patients it's going to be a long time till they're as good as they're going to get, but I tell them by 3 months I'm going to want them to try to do everything. Overall results are good. Patients will regain about 3/4 of their normal grip strength, their normal pinch strength, what they might have had they never been arthritic in the first place. You can get into problems with radial sensory neuritis with this exposure. There have been some exposures described that go deep to the abductor thenar muscle fascia to avoid that. But it's really, most of the time, it's a very transient thing. If you detect CRPS, you go after it right away. Don't let it get to the point where they're getting stiff. So for operative treatment, pretty much all forms of treatment, from the most simple to the most complex, can give you a good result. There isn't any urgency at all to operate on these people. It's never an emergency. You try and nurse people along as you can to make sure they need it. And if they need it, those are the ones that'll do the best. Simple trapeziectomy and maybe denervation too, time will tell, will work well in many patients. And trapeziectomy and LRTI and similar procedures is the most common procedure done in the United States and Canada. It works well. It's not hard to do. It's a little longer than doing a suture suspension or a simple trapeziectomy, but still ought to be well under an hour. You just want to pick something you know how to do, keep it simple, minimize cost and complications, and just get good at what you do. So in summary, the CMC joint's a mobile saddle-shaped joint. The stability is a combination of articular congruity and ligamentous tension from the dorsal ligamentous complex. That pathogenesis is a combination of ligamentous laxity, bone wear, and hyperextension of the thumb MP joint. Non-operative treatment can be very effective, and you should pursue it as best you can for as long as you can, explaining to the patient that you're never missing an opportunity by delaying surgery. All forms of surgical treatment can work. Our literature suggests that the form of treatment with the lowest complication rate, the lowest reoperation rate is going to be an LRTI or something very similar to it, though there is some suggestion that modern implants, particularly press-fit implants, may have a place in future management. Keep it simple, and if possible, keep it cheap. Thanks very much for your attention.